Thank you very much for the introduction. I would like to thank Professor Koufakis for the very kind invitation to be here today. These are my disclosures. First of all, let's define remission. Remission is defined according to a recently published consensus in diabetes care some years ago. SHbA1c levels below 6.5%, measured at least 3 months after stopping any glucose-lowering drug. So why is remission important? Why are we here to discuss about this interesting topic? We all know that type 2 diabetes is a nasty disease, is the commonest cause worldwide of blindness, the commonest cause of adrenal stage disease. And maybe it is very important, not important for us as physicians, but it's very important for the governments, for the politicians, that it has been estimated that approximately 10% of the total money that the European Union spends for healthcare costs is associated with diabetes care. And it is very impressive and also very annoying to see this data showing that type 2 diabetes is associated with poorer survival rates compared to many malignancies such as breast cancer or some lymphomas. And even today, we live probably in the era with the better anti-diabetes drugs, GLP-1 receptor agonists, SGLT2 inhibitors. Still, type 2 diabetes continues to reduce its life expectancy for the people who live with this disease. And it is also very interesting that if we ask not the scientists, not the researchers, but if we ask the patients that live with this disease, which will be the first priority for their future research in type 2 diabetes, patients will answer that the first priority will be to find a definitive cure for this type of diabetes. So remission is important because, as we will find out in the next few minutes of my presentation, it can avoid or reduce the risk of diabetic complications. It can self-motivate it can also reduce the burden of medication. This is important both for people who live with type 2 diabetes, but also for the healthcare systems. It can lead to reduced diabetic stigma. We all know that diabetic stigma exists in our societies. And finally, also important for the healthcare systems, that it can reduce the costs associated with life assurance, mortgage, travel insurance, etc. So how can remission be achieved? There is no doubt that obesity, the increased BMI, is a major driver for the development of type 2 diabetes. And we know, we have good data that if someone loses a modest weight, this can result in impressive reductions in the future risk of diabetes development. For example, we know from the diabetes prevention program that losing 5 to 7% of the baseline weight can reduce dramatically the risk by 58% of the future type 2 diabetes development. And these are some interventions, dietary interventions that have been tested in various studies for achieving remission. You can see that there are heterogeneous interventions, keto diets, low carb diets, meal replacements. There are different approaches. But I would like to stay a little bit more on this trial. The direct trial, in my opinion, was a landmark trial in the field of diabetes remission. This study was conducted in Scotland and England. It randomized participants in 2 arms, the control arm in which people received the standard diabetes care, and the intervention arm in which participants received the structured weight management program. It is important to underline that this trial was led by primary care physicians, not by experts in diabetes. It is also interesting to highlight that it included subjects with a relatively short diabetes duration, below 6 years. And in the direct trial, you can see that the intervention arm lost weight. And I think that if we should keep a magic number, this is the number 15. The trial showed that if a patient loses more than 15 kilograms from the baseline weight, then the probability of achieving remission is very, very high. But also the direct trial highlighted some benefits of remission beyond glucose control. For example, you can see that people who achieved remission also experienced significant reductions in blood pressure, and this was achieved with a fewer number of medication. Also, there was an improvement in cardiovascular risk scores. I'm not talking about cardiovascular events, but those who achieved remission in the direct trial reduced their cardiovascular risk score, which is important, I think. But maybe the most important is that people who achieved remission also improve their quality of life. I think this is very important for our patients. And we all know that fatty liver disease is a very common comorbidity of type 2 diabetes. So in the direct trial, people who achieved remission also reduced their liver fat content, then pancreas fat content, and also improved their lipid profile. And with regard to the mechanisms that might explain remission, you can see that losing weight has been associated with improvements in pancreas morphology and also improvements in beta cell function. And this is another interesting study, an observational study from Scotland also, which showed that achieving remission is associated with a lower risk of both micro and macrovascular complications. It is important to highlight that from this study, it seems that remission will benefit more young patients with a low complication burden. So if a patient wants to try to achieve remission, I think the right time to do that is shortly after diagnosis. And finally, a sub-analysis from the direct trial, which shows that actually achieving remission might be cost-effective because obviously it can reduce the burden of pharmacotherapy and complications for the healthcare systems. So I think a strong message from this trial is that if one achieves a remission, it can, he or she can live longer, feel better, and cost less for the healthcare systems. Just a few words for intermittent fasting, which is gaining increasing attention in the literature. I think that we will discuss more and more about this type of diets in the future. In the last few years, we have published a number of papers from our group exploring the metabolic effects of TRE, of time-restricted eating, compared to another dietary model, compared to the orthodox religious fasting. These are some of our papers, and this is the latest one, in which we observed that people who practiced intermittent fasting experienced significant reduction in both body weight and fat. We also showed significant improvements in fasting glucose in the arm which practiced TRE. We didn't see any changes in adipokine levels. Interestingly, we showed beneficial effects on glucose metabolism to be mediated by changes in amino acid intake, which I think it's interesting because traditionally we think that amino acids don't play a major role in glucose regulation. But we had a relatively short follow-up period, just 12 weeks. We probably need a longer follow-up to establish a significant association between remission and this type of diet. It is also important to highlight that it seems from the data that weight loss is the key determinant of remission and not diet composition. You can see that in the literature, remission has been achieved with different dietary approaches, with Mediterranean diet, with low-carb diet, with keto diet, with high-protein diets. So it's not very important what type of diet your patient will follow. The key thing is to lose weight. And what about physical activity? This is an interesting meta-analysis which shows that diet has a larger effect on total body weight loss, but on the other hand, exercise seems to have a greater effect, a greater beneficial effect in VAT, in visceral adipose tissue, and we all know how important is VAT for the metabolic health. And probably combining the two approaches, combining diet and exercise, seems to improve remission rates. So there are some challenges in pursuing intermittent remission. This is sure. In the Orthodox tradition, Apostle Paul was a very fanatic slaughterer of the Christians. And in his road to Damascus, Paul sees a vision and he is transformed within 1 second from the fanatic slaughterer to the best student of Jesus Christ. So I mean that ideally in our clinical practice, we wish our patients to have the road to Damascus experience and change their lifestyles within a moment shortly after diabetes diagnosis. But as you know from your clinical practice, this is very, very difficult. It's very difficult for our patients to change lifestyles and adopt a healthier one. Another challenge is that we have seen that benefits in mortality are observed only with metabolic surgery. As I previously said, remission seems to improve the probability of diabetic complications, but regarding specifically mortality, this seems to be reduced only with surgery. Maybe it is the magnitude of weight loss. To reduce mortality, one has to lose a lot of kilos. Maybe there are other mechanisms that are involved. For example, we know that metabolic surgery leads to improvements in the hormonal environment. Another challenge is that it is relatively easy. This is what data, research studies, but also the clinical experience shows. It is relatively easy to lose weight. The hard thing is to retain weight loss in the long run. As you can see, after an initial period of weight loss, then people tend to regain the weight loss. And this was also confirmed by the findings of the direct trial, which actually show that as time passes, the probability of remission, the rates of remissions dramatically fall. And finally, another challenge is that maybe there are not all patients ideal for very aggressive weight loss strategies. For example, we know that there is a U-shaped association between mortality and BMI, which means that people who are at the higher BMIs have a greater probability to die, but this is also applicable to people with very low BMIs. So losing weight very aggressively is not the ideal strategy for every person. To conclude, an interesting question is why not combine lifestyle change and medication, at least in some people. This is one of our recent articles in which we suggest a very aggressive approach in people with recent type 2 diabetes diagnosis. We suggest that apart from lifestyle changes, which are of course always important, we can combine both of this new drug category, GLP-1 receptor agonist and SGLT2 inhibitors, to induce a reduction in body weight. But we also know, it was previously mentioned in some of the previous lectures, that these drugs have also very important pleiotropic actions. They can prolong maybe life expectancy. They have remarkable cardiorenal protective properties. Just to remember that the guidelines suggest the use of these agents independently of the baseline glycemic control, especially at those who are at high cardiorenal risk. So personally, I will be very reluctant to stop any diabetes medication, especially these new drug categories in people who are at high cardiorenal risk, even if they achieve diabetes remission. So my take-home message is, first of all, remission is an emerging target in the management of type 2 diabetes. I expect that we will discuss more and more in the future about this therapeutic goal. The major determinant of remission is weight loss. It's not exercise. It's not the type of diet. The key thing is to lose a lot of weight. Unfortunately, it is very difficult. It is almost impossible for most patients with type 2 diabetes to retain weight loss in the long run. This is true. We need more prospective data on the association between remission and complication risk, although preliminary data are promising. And finally, lifestyle intervention and medication can be combined, especially in those who are at high cardiorenal risk. Very recently, we published a review in Nutrients in which we discuss in very analytically in detail all these aspects of remission. It is open access. If anyone is interested in reading more, he or she can download it. And I would like to thank you with a phrase of Charles Kettering, who was a mechanic. He used to work for the General Motors company. He did a lot of innovations in the field of car industry. And Charles Kettering said that if you have always done it that way, it is probably wrong. I think that remission is a new and probably a better way to do things in type 2 diabetes for our patients. Thank you very much.